Our next speaker is Brenda Nevidjon, RN, MSN, who is the Chief Executive Officer of the Oncology Nursing Society, a professional organization of almost 40,000 members. Ms. Nevidjon was the first nurse and the first woman to lead Duke University Hospital as its CEO. Ms. Nevidjon is a nationally and internationally recognized leader and advocate for oncology nursing, focusing on continuous improvement in the quality of oncology care. An extensive contributor to the nursing and medical literature, Ms. Nevidjon is a mentor for nurses, encouraging others to contribute to research and publication. She is a graduate of Duke, UNC, and the Wharton Nurse Executive Program. Thank you.
Thank you, Randy. And good morning to all of you. I am very pleased to be here and recognize that this is our 9th year, the Oncology Nursing Society being a member of the National Cancer Policy Forum, and very proud to have contributed these number of years, and love coming to this meeting as in the audience as some of you are here today. So I'm going to talk about oncology nursing, but first we have to start with nursing, since oncology nursing is a subspecialty. So right now it is probably greater than 3 million, depending on what source you read. That could be 3 million, that could be 3.4 million, which leads me to draw the conclusion of we have improvement to do in terms of how we capture licensed nurses in this country. But with that said, the HRSA has done a study projecting to 2030 and are projecting that there will be 3.9 million registered nurses by that time. But there are some interesting things that are a subset of that, and you will see that the average age of nurses entering the workforce are 30. When I graduated from nursing school, that was more like probably 21, 22, and we've seen not only an aging of the workforce with the average age of nurses in practice being 50, but we see an average age of entering the workforce, thus graduating from their programs, aging as well. Nursing tends to be the largest percent of many organizations, many healthcare organizations. So when you look at the budget and you look at line items and you look at your personnel line item, oftentimes nursing is the largest, most expensive part of that personnel budget line. While we have done many things in nursing to try and capture how do you staff? How do you staff an inpatient unit? How do you staff a clinic? How do you staff an infusion center? We have inadequate tools to measure how that staffing is, and yet we still continue to try and figure that magic number out. And for 17 years, the Gallup survey has had nursing as the top trusted profession in the United States. And that is something that in nursing we don't take casually. That really reflects the trust that the public and our patients have in terms of what we bring to them. There has been national and now there is global focus on nursing. The book cover you see is The Future of Nursing, which was published in 2010. This report, at last I knew, was the most downloaded, is it still, Cheryl, the most downloaded report ever to come out of the National Academies. And there is now a group looking forward at Nursing 2030. And some of what you're going to hear today, not just in this session, probably as today and tomorrow go on, are things that were recommended in this report about nursing. Nursing Now is a global initiative right now. Some of you may remember the news that the Duchess is a sponsor, a champion of this, Duchess Kate. And this is really looking at elevating the profession globally. We live in a country where I believe, and obviously with the Gallup survey, we have good status, good scope of practice. That is not true around the world. And so in the next couple of years, there's some major initiatives going on to elevate nursing in other countries. So there's some trends that are occurring. These are going to seem similar to even the first. The aging population I told you the average age is 50. I would also note that the average age of faculty is a little bit older than that, and I'll come back to faculty a little bit later. But there is an increased demand for nurses in all settings that we're seeing. The baby boomer nurses are retiring. We estimate that 1 million will retire between now, and they started retiring a couple of years ago when the first baby boomers turned 65, and it will increase to 2030. Nurses, depending on their setting, may remain longer. But if you think about the hospital-based nurse and the physical intensity, and so many of our hospitals on 12-hour shifts, the likelihood of a nurse still there in the site at 65 is rarer than common. In the outpatient center and in home health and all, nurses may stay longer in hospice settings, but the physical demands as well as the schedule demands are in the hospital setting. So you may see more turnover if you're at all engaged with hospital care. Part of this is also we're losing an accumulated knowledge and clinical expertise base. So what we're seeing is a shift in many settings, including in areas that traditionally didn't hire less experienced nurses, such as the ambulatory setting. We're seeing a shift towards a younger, less experienced, less knowledgeable generation. And I think all of us are going to be challenged with how do you retain some of that expertise and coach and mentor younger nurses. For a new grad, it is not unreasonable to expect that it will take them a year to get confident with what is needed and done in a clinical setting, be that the tasks, be that the EHR, whatever. And that by their second year, that's where they're really beginning to integrate their knowledge and their confidence. Yet we expect a 4 to 6 week orientation and that a new grad should be fully functional, which is quite unrealistic. And then obviously there are some national projections occurring. We know that schools of nursing have expanded enrollment, but we also know that each year there are thousands of qualified applicants who are turned away because even that expanded enrollment is not sufficient. Depending on who you read, we may be having a surplus now of nurses, although it may not feel that way in some geographies. That's due to the uneven distribution. And again, it's not just numbers, it is the knowledge and experience. So we have some areas of the country where you have a much younger average age workforce than other areas. Actually, some of the heat maps we've seen in the prior two reflect nursing also. I was noting with one of Suwana's that the distribution of the bubbles that were mostly east of the Mississippi, that's exactly how a nursing, oncology nursing distribution is too. But I want to show you the projection. So we are going to have states that are going to have quite a bit of surplus, according to the projection, as we're heading towards 2030. And we're going to have states that have shortages. And this came out of the HRSA simulation model of taking demand versus the supply projections and all the things they put in their model. I'm not going into details about that. But you can see the variation here between where surplus and shortages are going to occur. And if you think about, even depending on the community you're in, we have history in nursing, for instance, that during the shortages of the 80s and during the shortages of the 90s, that nurses, or nursing students coming out, say in the Boston area, couldn't find jobs in hospitals because hospitals were so fully staffed and there was very little turnover. And so they struggled to find jobs there. So we know there have been communities where when new grads come out, they can't get the job experience that they're looking for. You heard a little bit about the trends in oncology physician population, but we are anticipating shortages of physicians when you look again at HRSA modeling and other modeling of primary care and some specialties. And again, the issue of uneven geographic distribution of perhaps overstaffed in metropolitan areas, well understaffed in rural areas. We've had a change, and so obviously we were talking, or Suwana was talking a minute ago, and we were listening to about the use of APPs. We know that they also have an uneven geographic distribution, but also there are some things happening in nursing around education of advanced practice nurses and nurse practitioners. And we are in a conversion of the definition and the delivery of advanced practice education, so that whereas in the past an oncology nurse could go back and get a master's degree to be an MP, and in that course really specialize into an NP role using oncology as the clinical. Now, the future is going to be that nurses will start with the population education, be that pediatric, be that adult gero, et cetera, and that this subspecialization, whether it be cardiac, whether it be diabetes, whether it be oncology, will be an add-on. It will not be the foundation. And so it's getting slowly ramped up in the country. And then layer on top of that, there is the intent that all advanced practice nurses will complete a doctor of nursing practice, and that the master's curriculum gets folded into the pathway from a bachelor's to a doctorate, and that the terminal degree will be that doctorate. I mentioned a minute ago about faculty shortages. Some of that is the aging, but it also is a decline in nurses entering PhD programs. We have seen the doctor of nursing practice enrollment and graduation accelerate greatly, exponentially, and the PhD is in a slow decline. Some of that, I think, is because many nurses in the past who wanted doctoral work may not have really thought that they wanted it for a career as a nurse scientist, and maybe they didn't go into an academic role because there are doctorally prepared nurses in all different kinds of settings. But with this clinical doctorate, it is appealing to more nurses to come into that. And that doesn't mean they can't be faculty on schools of nursing, but it is leading to some interesting dynamics in the academic world for nurses. Just wanted to put up there an oncology nursing definition, but I really want to tell you what this is in the words of an oncology nurse about why it was a great choice. This was written by Lisa Begg, who is the first president of ONS back in the 1970s. And she said, if you want to combine a career that trains you and challenges you each and every day to witness and participate in all of life's joys and sorrows, nursing is the career for you. Nursing teaches you how to substantially communicate with other people, from everyday conversations to those involving life and death decisions. It is also a very technically challenging field that brings you to in contact with a full range of healthcare professionals and the public. I used to say that nursing taught me how to live, and sometimes how not to live. We are participants in many of life's important events, but we also get to observe life at its best and worst. By working with patients and their families, we witness many of life's high points and low points and learn from these experiences. And I think many nurses will say that nursing chose them. They may not have chosen nursing, and I think you can hear that in how Lisa speaks about this. So past oncology nursing, I've told you about nursing. We're a subset of nursing. We come to oncology nursing through a choice after we graduate as a registered nurse. There are many, many specialties that compete for nurses. There are many settings that compete for nurses. Once nurses are out as registered nurses working, they then have the choice to go back to school. As I mentioned, some will advance their job pathway in different kinds of roles, from that nurse at the bedside or chair side into different kinds of roles. They then can advance education as advanced practice nurses or nurse administrators or nurse scientists. But there are some trends that are happening, and I thank ACCC for their trend reports every year. But I wanted to just briefly show you from 17 to 18 some of the things that are consistent trends. Certainly staff turnover and vacancies are, the employment of nurse practitioners and APPs are, but you can also see practices are adding the nurse navigator. They're adding palliative care advanced practitioners, they're adding genetic counselors, and they're adding financial advocates. And one of the things that we know in terms of the workforce is it's not just the nursing workforce or the physician workforce, it's other professions that also we have a shortage of, for example, the genetic counselors. So how big is the oncology nursing workforce? Well, unfortunately, in nursing, we don't really capture accurate data about the end. But this is how I look at it. In 2013, 15, and 17, on our National Nursing Workforce Survey, we had either 2.8 or 2.9% of the nurses who responded to that who identified as oncology nurses. That means approximately 90,000 nurses in the country are oncology nurses. If we use that same percentage with the number of NPs, we have even weaker data about oncology nurse practitioners, as Suwana mentioned. Maybe we have 7,800, but I doubt that. So again, it's not an infinite number. I do want to touch briefly, and you're going to get a bigger session on this, though, of the care team well-being as part of the quadruple aim, and particularly what's happening in the National Academy. Burnout has always been a theme through nursing and oncology nursing. There is a difference between burnout and something that emerged about 10, 15 years ago, and that's understanding compassion fatigue. And we've had a fair amount written in the oncology nursing literature about compassion fatigue. But you see with the burnout situation, and what's different, I believe, than our report from 2008, is burnout is now what we're seeing in medicine. Burnout is now what we're seeing in other professions. It's not simply nursing, and it wasn't necessarily there in the other professions. And so leaving the workforce is what happens in a burnout situation, and where we probably are seeing attrition. So future considerations, definitely, we have to think about where do we have wasted energy, and I throw these up here to be provocative. I'm not going to answer them, but that there are things that I think many of us would say, and there are many other things that may be wasted energy and time. I would mention in terms of pre-authorization, a recent AMA survey, the respondents, the 1,000 physicians who were interviewed, 14.9 hours a week on pre-authorizations, and then their concern about delay access to treatment and consequences to patients. And then future considerations to improve the oncology team-based care. You're going to hear about some of this. I just wanted to highlight we need to do education a different way. We need to tap into the talent of our faculty and do more interprofessional education than siloed education. We need to make sure in care delivery, whatever we do, that we are maximizing the skills and the scope of the practitioners there, that the current technologies solve problems, not add to our problems and our frustration, and to advocate for policies that will support the change. What we're doing as a society is we have begun to work upstream and trying to influence nursing education, and we've developed resources for pre-licensure programs, and we're evaluating that now. We had several schools of nursing test this with us. We are collaborating with other nursing organizations in terms of oncology because we know med-surg nurses, ER nurses, and so on, they also touch cancer patients. And we have a postmaster's course for non-oncology NPs who are being hired into the workforce. So thank you very much. I'm glad to be here. And I look forward to our discussion.